I'm going to hand over to our chair for today, Shazna. Welcome, Shazna. You just need to take yourself off mute.
Off mute now. Good afternoon and welcome everyone. Good start. My name is Shazna Kanom and I'm delighted to be your chair for today's webinar. I work for Connect Health as Director of Mental Health Services and look after the mental health arm of the service. Our significant experience in long-term condition management through 30 years experience in MSK and pain extends to working in partnership with IAP services to provide IAP counselling, which improves patient choice and reduces wait times for patients entering treatment. You can find out more about the work we're doing, for example, in Heart's IAP counselling service. That's on our Connect Health Change website. Now, we've been running the Connect Health Change webinar series since July 2020, and we've been covering a broad range of topics, for example, unwarranted variation, virtual consultations, chronic pain, long COVID, psychology, service redesign, first contact practitioner and education, and quality improvement. Very exciting. The next one in the series covers health inequalities, which is in March. That's followed by assuring the MDT workforce, which would be in May. And just to point out that all our past recordings, along with our Q&A summaries, can be found on the Connect Health Change web page. So today's topic then, mental health, are we doing enough? And we have an impressive lineup of speakers, and you can find their full biographies on the web page as well. Each presenter will speak for about 10 to 15 minutes, followed by any immediate questions, but we will take the majority of the questions at the end, and I would encourage you to post your questions in the Q&A. Now, there's never been a more crucial time than now to reflect on whether we are doing enough in the mental health space. The Centre for Mental Health publication titled COVID-19, the nation's mental health, confirms that 10 million people in England will need support for their mental health as a direct result of the pandemic over the next 3 to 5 years. Now, those figures are concerning enough, but what's even more concerning is that the predicted levels of demand are 2 to 3 times higher than the current NHS capacity, and that's despite additional investments. Specialist bereavement support, people economically impacted by the pandemic and survivors of severe COVID, along with health and care workers, are being adversely affected and need specific services. Now, mental health and physical health services on the whole are still being treated separately. And we know that the cost of this is higher and the health outcome of this is poorer. Now, this webinar will consider where we are now, what needs to happen, and where the sector is going. It will hopefully unearth issues around the workforce, physical and mental health integration, and we'll look at what digital and virtual services have to offer. So what we're hoping to explore today is how big the current problem is, what are the latest insights, what is the latest learning from digital innovations, how can we improve access from a patient's point of view, how do we deliver effective and accessible therapy for everyone that needs it, and a look forward, what's exciting, what are the coming challenges, and what can we look forward to. So it gives me great pleasure to introduce our first guest speaker, Laura Karku. She's the Senior Project Manager for Improving Access to Psychological Therapies, this IAPT, for NHS England and NHS Improvement, and she'll be reflecting on ways to optimise IAPT service delivery with digital transformation. Just before I hand over to her, I'd like to quickly add a note that we are very sorry that Hayley Matthews, IAPT Programme Manager, is unable to join us this afternoon. She had a last-minute conflict in priority, but we are extremely grateful to Zora, who is going to touch on the national perspective, and we'll be happy to answer questions at the end. Over to you now, Zora.
Brilliant, thank you. I'm hoping I've just unmuted myself. Thank you for the introduction, and I should just say that you can see that I have slightly stolen some of these slides because I'm not in fact Senior Programme Manager, I'm Senior Project Manager, but I stole this from my colleague Julie's slides. So just to clarify, could I get the next slide, please? Okay, so I'm going to spend the next 10 odd minutes talking you through the IAPT national team's perspective on digital transformation. I'll talk through a bit of context, what's been happening in the system, particularly through some of the changes that happened through COVID-19, and then talk through some of the really exciting stuff that's going on in the system just now. So next slide, please. Okay, so without reading through the slides, just to give you a bit of context, essentially, I think the IAPT national team and possibly quite a lot of IAPT is a bit obsessed with access at the moment. And that's because we have a very ambitious target, 1.9 million people reached by 23-24. We know that we are under that target trajectory at the moment. We're at somewhere like 71% of where we want to be. And while the bulk of the shortfall in the access can be attributed to slower than planned workforce growth, and I really want to recognise that that is an issue, it means that services don't have the capacity to treat the required numbers, but there are peripheral actions that we can take to support the expansion in access. So today I'm going to focus a little bit on access and just talking through those issues and how digital has helped us with access and continues to help us with that, and then talk through a bit of the rest of the IAPT pathway. So as soon as COVID-19 hit, one thing that changed, like in many different workplaces, is remote treatment delivery. So services switched to some video services and then also treatment by telephone. And one thing that changed around that time was remote outcomes reporting. So our main system suppliers were able to enable mobile phone entry of the minimum data set and patient experience questionnaires. And what we've seen is a roughly 16% increase in the numbers of people completing those. So that's been a real success story, I think. And it's a real, although it was a difficult time, it was a real interesting thing to see how we could positively impact our KPIs, but using technology. So next slide, please. There we go. So the two key areas that we're thinking digital transformation can help is around productivity and efficiency benefits. The first thing is reducing the average clinician time per patient or per course of treatment so that clinicians can see more patients in a given amount of clinical time. And to give you a couple of examples of what that looks like, one is, for example, digital tools facilitating the treatment of facilitating the delivery of group treatment. Lots of big words there. And the other is digital therapy programs, which could be an option for patients to learn online through self-study. And although there's still ongoing contact with a therapist, it just means reducing that average clinician time per patient. The second way is removing non-clinical tasks from clinicians so that clinicians can do what they do best and spend more of their time on clinical duties. And that means less time on admin. And an example of that is digital tools to collect outcome measures. So in that beginning part of a treatment session, the clinician doesn't have to spend time collecting data that's already been done before, either by SMS or an online system. Another way is electronic booking systems, where patients are sent an SMS and are able to book in their own appointments, which saves time for people calling up patients and having to book them in manually. And another is remote platforms that interact with health records. So at the beginning of the process, right at the beginning of the pathway, where a clinician might normally need to contact different systems, different parts of the system to understand what, for example, physical health a patient is in, or what records they've been in, things like A&E visits and things like that. Where traditionally they may have had to make some phone calls or some inquiries, it's possible for them to use digital to click a button and see the previous history. Next slide, please. So this is a simplified version of the IAPT pathway. And what we wanted to do here was really just point out that there are lots of things that we can do right the way from the beginning of the pathway through to the end, and then possible re-referral or discharge and supporting discharge. And so I'll take you through this. I'm going to spend a few minutes just going through these. One of the things we've been doing in the national team is actually looking at what's out there already. There are so many fantastic, really innovative, really interesting things going on in services across the country. So one of the things that we've tried to do is to collect all of those in the form of case studies and put them out to the rest of the system so that they kind of empower and inspire. And it also means that if you are a clinical lead or a manager in a service and you're thinking, oh, I wonder what we can do to help with triage, for example. You don't have to start with Google. You could start with looking at what everybody else has been doing in that space. So just quickly going through these 6 areas. The first is awareness, very much an access-led focus. The second is referrals, and it's quite key there, the improving appropriate referrals. So it's not just referrals, it's also appropriate referrals, people who we can treat with an IAPT. And if we can't treat them through IAPT, then making sure that they can get to the right place quicker. Third one is making it easy for people to book and rebook appointments. And that's what I was talking about earlier around online booking, SMS, and patients really being able to take charge of making their own appointments. Supporting people whilst they're waiting for assessment and treatment is a really interesting one, because in some services they found that engaging at that point of the pathway means that you have a reduced number of clinical sessions required for the patient, and also that you can acclimatize patients to the therapeutic setting before they get into treatment. Later on is treatment, and that's around things like digitally enabled therapies, where you might have platforms which are a bit more self-study led, even though they do still have contact with the clinician, which is really important, but just maximizing that clinical productivity by giving patients self-study. And the last bit is the enhancing ability to share records, which I've already talked about. And one thing I might add there is a discussion a bit about discharge and what that might look like, and how we might use digital to essentially have more effective discharge. Next slide, please. I'm hoping you can all read that. You might need to increase the size of your screen there, but I thought I'd talk through just a few of the actual innovations and projects that people have been using. And just talking through some context of how we envisage people using digital. It's not a kind of, oh, what software could we use and let's just install some software. It's really about looking at the system as a whole and really looking at user-centered design and thinking, okay, well, where do we think we've got issues in the pipeline, and what can we do about them? And really thinking about clinicians and their perspective, thinking about patients and their perspective, and coming up with the right solution, which then may be a technical solution and may be a platform. But starting off with that just means that you've got the right insights and the right focus when you are picking a piece of software. So the software selection is almost the last thing in the process. So just going to go through a couple of these, not all of them, but the beginning one, SMS, I've said, I think is really important. There's lots of evidence saying that it helps, and in services that have already piloted it, we've got about 25% of the system using SMS currently to help patients book appointments, and we're hoping that will increase. Social media has been a very interesting one. People using social media, particularly around equalities and trying to reach patients who they have historically found difficult to reach. And that's actually across pretty much every one of the 9 protected characteristics around, for example, underrepresented ethnic minorities, the LGBT community, students over 65s that we have particular issues getting in touch with. And so social media has been really helpful, and those are some of the case studies that we've got there. The second bit around referrals, online screening and triage. I'll mention we're hosting a webinar in March around NHS innovations, and there's a team who've created an e-triage platform. And that's a really interesting one to make sure that people are accessing the appropriate level of care. And again, that if it's not appropriate to treat them in IAP, that they know where to go, not sort of lose them through those gaps. Booking and rebooking, I think I've talked about enough, so I will move along to the waiting for assessments and treatments part. And that's really using apps, text messages, video. We've got a couple of services who've done things like introduced video series. So there are actual courses that you can go through, worksheets that you can work through, some self-study that you can do, which is not technically treatment, but just engages patients and makes sure that they know that we're still holding them and holding them better than not communicating with them at all. The next bit is evidence-based therapies, and here we've got a particular project running around assessment criteria. I will pop the link into the chat as soon as I finish talking. But essentially what we're trying to do is to evaluate whether pieces of software that say they treat patients and deliver IAPT treatments are any good. And this project started a couple of years ago, but we're actually in the pilot stage at the moment. We're accepting feedback also to what people think the assessment criteria should be. How should we know whether a piece of software is any good at all? And it's a two-stage process, and mainly there are some really basic checks, like does it deliver treatment that is one of the 13 IAPT conditions? What's the evidence of effectiveness and things like that. So if you do have any feedback, that would be great. It's still open for feedback, and the assessment criteria pilots we're hoping will deliver their first recommend, not recommend recommendations by the end of April. The next bit is enhancing the ability to share records, and we've actually seen some real results from a case study which is up on Futures, which I'll link to later on, where you can actually, a clinician can actually click a button and find out what's been happening with that patient and their A&E visits, and some of their hospital records and things like that, which they estimate has shrunk their waiting list in some cases by something like 10 days for a particular patient, because they've got that information on hand straight away, just at the click of a button. And one of the PWPs working there said it was like a miracle. And I think that just reflects the the level of decreased frustration, I'm going to say, in getting those records quicker. The last point on that one is interoperability. So there are lots of systems which need to talk to lots of other systems, and we're currently running in a very user design way. We're currently running an exploration and figuring out what are the needs there, which systems need to talk to which systems, and what can we do to support that interoperability. So that will deliver its first results on what the current situation is at the end of March, hopefully, and then we'll be able to plan in a work stream of what we'll do about it in 22-23. Next slide, please. This is a resource I just wanted to focus your attention on. We've created something called the High Impact Digital Opportunities to Optimize IAPT Service Delivery deck. It's a resource, and it essentially takes each one of those 6 areas that we just explored and shows some real life case studies of actually what people did in those scenarios, how they did it. And there are more detailed case studies behind those, but it's just a kind of overview of what's possible. And I think it does read quite well as a kind of inspiration. And if you're looking for ideas of where to start, it's a good place. Next slide, please. So finally, I just wanted to leave you with some resources, places to go for some more information. And I'll just emphasize signing up to Futures. There's a lot of discussion around digital on that future.nhs.uk/IAPT link. And some of it is around things like webinars, opportunities that are coming up. People post up questions around, oh, I'm looking for a piece of software that does this or that, and other people can feed in, which is quite helpful. But the other thing I wanted to draw your attention to on there is we're creating an IAPT digital network, and that's for people who are particularly interested in digital in IAPT. And again, following a user-centered design kind of process, we'll pop up a survey up there to see what people actually want, what kind of resources they're looking for. And hopefully that will be a nice place to really kind of focus on IAPT and digital. I think these slides are going out, so those links should hopefully work. And if there's anything else I can help with, or the national team can help with, please do get in touch. And that's me. Thank you.
Thank you very much, Zora. That's fantastic to hear. Lovely set of resources for us as well. That's amazing. I'm just really excited by this stuff. You know, I don't know if you know, I'm an IAPT trained CBT therapist myself, and I have managed IAPT services, and I was always very impressed by how IAPT was an early adopter of digital solutions, and they did lead the way a bit, especially in the mental health sphere. But seeing your presentation lets me see it, and it pleases me that actually it's been embedded into every step of the patient pathway. You know, not just from booking, and not just, okay, we do step 2 work via telephone, or we provide, you know, online packages. It's you know, right from pre-referral right through to discharge. So cool stuff. Thank you for sharing. It made me think though, you know, your presentation where the slide where it highlights the pathway from awareness right through to discharge. Is there any merit or value in, or even demand for it going the pathway following a patient past discharge, you know, for even when they've been discharged, to have a portal, say, where their therapy blueprint is there, the resources that the therapist shared is there, or any worksheets that they worked on. And I'm just thinking of like relapse prevention here, or like, how do people keep themselves well? Is there something that IAP can do, or the digital solution can do to help that as well? What do you think? Sorry, very worded question, I'm sorry.
Yeah, that's fine. Oh, no.
Oh, you've unmuted. You've muted. Oh, I think you're muted there, Zora.
How's that? Any better?
Yeah, yeah.
Oh, thank goodness. Sorry, my computer is not happy today. So that's a great question, and funny enough, in that webinar on digital opportunities that we're putting up, hopefully March 15th, there is an app called Paddle App, which is another NHS funded and NHS implemented app, which does exactly what you've described around things like making sure that patients can collect their own homework, they can interact with it, and so that beyond their therapeutic sessions, so let's say you've had 6 sessions or 8 sessions or whatever it is, that afterwards you can then still go onto the app and still go back and refer to sessions, and absolutely it holds patients after discharge, which we're hoping, and we'll see the evaluation isn't quite in yet because it's very new, but I would say that Inika, who's leading on it, is going to talk through the entire process and the whole app at the webinar, so watch the space and come along.
Thank you. I certainly will. That sounds really interesting. I do have one more question, and there is time for it, I think, if that's okay, Zora. What should IAP and counselling services focus on to improve access to services?
It's another great question. I think really just going back, and maybe since we've got the time, maybe if you go back a couple of slides back to the 6 sort of, or the pathway. What I would do is start with looking at your pathway, and really in a very sort of user design and user-centered kind of way, is think about where your key issues are. Take those, and I really think that clinical leads and managers will probably already have an instinct into, oh, we need something here or we need something there, but really finding that evidence, having a look at where it is that you think you can make the biggest difference. Start there, and then there are actually lots of resources from NHS Digital around things like how to start a project, how to even think about, okay, well, we want to make a difference to, you know, how much time our clinicians spend gathering data, for example, or something like that. And there's some great resources and training around, well, from that point where I've articulated what the issue is in the first place, what can I then do to progress that and to figure out exactly what we need, and to get to the end of that process where we think, oh, okay, this is what we can do about it. So I'd say start there. On Futures, there are some great resources and links around where you can find that information. But that's what I would do, is start with defining the issues and then see what difference you can make. And I'd say there's also, since there's so much good stuff going on around the system, is have a look, connect, join the IAP Digital Network once it's up and running, and find out what everybody else is doing too, because there is a lot of expertise in the system. And of course, what works with one service might not work with another, but it's just a great starting point so that you don't essentially start off with Google.
Brilliant. Thank you so much. Really, really excellent advice. Good starting points. And I was scribbling down things, and then I realized it's okay, it's been recorded. I'm going to listen to it again. Thank you. Right, I will now introduce my next speaker, Emma Branch. She's the Chief Executive Officer for the Counselling Foundation, and she's going to speak about bridging the mental health services gap. Over to you, Emma.
Thanks, Shazna. Afternoon, everyone. Emma Branch. As Shazna said, I'm CEO of an organisation called the Counselling Foundation. If you could jump onto the first slide, please. Just to give you a 2-minute overview on who the Counselling Foundation are, we have 2 sides to our organisation. We're a training organisation, and we deliver mental health training, both short-term training and also longer-term training for people who actually want to become accredited as counsellors. And secondly, we're a provider of counselling services from within the voluntary sector. Both our training and our counselling services are BACP accredited. That accreditation and upholding the ethical and quality standards of a governing body is extremely important to us, because one of the challenges that we face in the mental health sector is it continues to be a very unregulated industry, which puts vulnerable individuals at risk of harm. Our counselling service is broad. We are a provider of IAP services, the service we've just been hearing about. We provide services for the police, working with people who are victims of crime, domestic abuse. We also offer employee assistance services. And most importantly, I guess for today, is we're an organisation where individuals can either self-refer or be referred to us by other voluntary organisations. And we're a charitable provider of counselling services. This part of our services is subsidised, and it's based on affordability that people can pay. We deliver remote or in-person counselling and at fees based on affordability. And I think one of the things that makes the service that we offer pretty unique across the whole UK actually is that we offer 30 sessions and longer term counselling. Many of our clients pay as little as £5 per session, and we make a real treatment commitment to them. If you could move on to the next slide, please. So I guess, you know, why am I here? Why is charitable provision important, and why in general is the sector known with the very exciting abbreviation of VCSEs, which is voluntary community and social enterprise organisations critical for mental health services? And I wanted to illustrate this point by giving you a couple of client examples. On the slide, you can see quotes from service users, one of whom self-referred to us and one of whom was referred to us by another organisation. One of these individuals was battling with PTSD from childhood trauma and had been assessed as too symptomatic and high risk for IAP short-term work, and another was struggling with a personality disorder. Both individuals were facing an extremely long wait for therapeutic support via the NHS pathway. And, you know, I think the quotes, you can read them for yourself, are really telling of the desperation these individuals felt. As a voluntary service, we were able to clinically assess both of these clients within 2 weeks. We were able to allocate them to a counsellor with the appropriate experience to meet their clinical needs. And by that, I mean counsellors who knew how to work with their clinical presentations and who had the appropriate clinical supervision to make that therapeutic work safe. And both clients started treatment within 5 weeks of us receiving their referral. And most importantly, we were able to continue to liaise with other services such as their GP or the CMHT to ensure an integrated client care pathway. Next slide, please. I give these examples not because I want to criticise the amazing work that is done by so many people in the NHS mental health sector, but I don't think that many of us would disagree that mental health is a sector that has historically been underfunded and remains fragmented. And although change is trying to happen, making change within the NHS, particularly when trying to integrate that change with other statutory support bodies, is like deciding to turn an oil tanker from pointing north to pointing south. And that's down to the size, complexity, and just competing needs that there are across our health system. VCSEs, on the other hand, I believe, have the ability to be agile. We service a much smaller population, which can lend itself to flexibility and can also enable us to provide more client-centric tailored care under some circumstances. Importantly, we can be streamlined and make and implement decisions quickly, which enables us to be responsive to current health challenges in our communities. Many VCSEs also act as centres of excellence, of expertise. We can see that in the work of many of the amazing voluntary organisations that specialise in areas such as eating disorders or addiction. Having these centres of excellence often helps with attraction and retention of workforce, and likewise the culture of the voluntary sector can also be attractive to workforce. And we know ourselves that workforce attraction and retention in the mental health sector across the whole NHS is one of the biggest challenges that the sector is facing currently. I believe as a small organisation, we also have cost efficiency at our heart. We are small enough that a cost efficient mentality is held throughout the whole organisation. I can say with a passion that I know that everyone who works for the foundation knows that a penny wasted is a penny that adds to the risk of closure of the service and is money that could be spent supporting those with mental health challenges. And as I said before, the fact that we're a voluntary organisation does not stop us being able to liaise with GPs and other statutory bodies as appropriate for the client needs. Next slide, please. So I guess what does the future hold? I think historically the voluntary sector has in some ways been viewed with suspicion by some statutory bodies, but I am optimistic that that is gradually changing. 2 years ago, the government published the Adult Community Mental Health 5-year plan, which is now in its 3rd year. This plan encompasses the integration of primary and secondary mental health teams and social care services, but importantly, the must is it must also include strong representation from VCSEs. During the first 2 years of the transformation plan, approaches to the framework were piloted in some areas of the UK, but now we are in year 3. All CCGs, or ICTs as the new areas will be called, are in some phase of implementation. The transformation framework explicitly states that VCSEs are to be part of core governance structures, and also importantly, alongside service users and carers, and together with our statutory partners, we will be responsible for the design, delivery and strategic development of new models of community mental health care. Equally, there is an explicit requirement for collaborative working between providers of services to the NHS. So this would, for example, include providers such as ourselves in Connect. We work jointly to deliver IAP services in Hertfordshire, and I think the fact that I'm here speaking today already demonstrates the fact that we work closely in partnership together. So for me, the transformation framework promises much, but seeing this come to reality is not without major challenges, and we must not close our eyes to how big these challenges are, what they are, and how much change is required. Next slide, please. I'm currently working with 2 different ICTs on the transformation, and I want to give you just a flavour of some of the challenges this sector is facing as these newly formed ICTs try to drive change. Firstly, there is an inconsistent approach across the UK as to how the framework is being implemented. This creates both risks of further inequalities across different areas of the UK, but it does also create opportunities for ICTs to really get things right for their local communities. Different ICTs are moving at very different speeds, with some ICTs seeming to have fully formed transformation groups with fantastic representation and voice, while others seem to be barely getting started. Again, for me, that raises this massive risk of simply increasing the inequality in mental health care that already exists across the UK, and ending up with even more patchwork, fragmented care. I already see this happening in the difference of pace with the 2 ICTs that I'm personally involved with. Another consideration, and this really sits with us in the voluntary sector, is safety and ethics. I've already mentioned that many parts of the mental health sector are unregulated, and I think care needs to be taken around partnership working and the ethical and safeguarding framework that the VCSEs working with ICTs have in place. And alongside this, there's also the basic challenge of ensuring information flow to ensure that even the smallest voluntary organisations know what is happening with the transformation and get involved. And a final and really, really big problem for organisations like mine is the need for sustainably funded partnerships without recurrent short-term tendering cycles. NHS procurement processes and the ongoing service requirements are often complex and time-consuming. This can make it impossible for small but excellent charitable organisations to actually respond to partnership opportunities, either because they don't have the resource available to respond to complex 200-page tenders, or to then provide the ongoing level of reporting and service requirements that many contracts require. I'm going to bring this to life with an example in our IAPT services, and Zoru herself mentioned that workforce in IAPT is one of the biggest challenges. So we work for a number of CCGs providing IAPT services. And there is variation in terms of the requirements of the IAPT workforces. To give you a flavour, the IAPT training that our counsellors have to go through is an additional 5-day training. And the intention behind this was good. It was to ensure that the consistency and quality of care provided by IAPT across the UK is consistent. Yet many counsellors who've already been through 5 years of training don't want to put themselves through another costly 5-day course, and the availability of funded places is limited. So we have a shortage of capacity of IAPT counsellors to deliver on the demand that exists for IAPT services. And yet different areas are managing this in different ways. Some are being pragmatic and saying we can live with counsellors who are extremely experienced and without the IAPT qualification to try and reduce our waiting lists, whilst other CCGs are maintaining the need for this additional 5-day training, and waiting lists for care can be as long as 6 months. This, for me, although the intention is service equality, at the current moment isn't equating into service equality. And finally, many voluntary organisations like our own have an underlying need for investment in our own infrastructure. Many organisations struggled for funds, particularly through COVID, and focused on frontline care rather than internal investments in things like digital, which I agree offers an amazing opportunity for the sector. Next slide, please. So, to sum up, the ambition and stated policy intention feels that they are absolutely the right ones. However, we should not delude ourselves that there is a long and complex journey ahead to turn this ambition into a reality. Proof of success of the journey for me would be that clients come to us as a result of client choice and wanting to choose our service, and through an integrated care pathway, rather than clients who come to our service in desperation and speaking about the experiences like the one I outlined at the start of this presentation. I'm looking forward to the future. We're an organisation that wants to be part of the change, and I thank you for your time today and look forward to any questions you may want to ask.
Thank you, Emma. You raised some really important issues really hard-hitting message. You know, the quotes that, you know, I read that on your first slide that really hit home how long the journey ahead really is. But actually also I'm thinking, you know, of your, you know, looking ahead and the ambition feels right. Actually, when we get it right, how rewarding that will be. And, you know, we work in collaboration, and I think that's worked really well. We've enjoyed working together, and that is the way forward, I think. I do have a question for you, Emma, if that's okay. What is the one thing that the newly formed integrated care systems could do to make it simpler for voluntary sector organisations to respond to procurement opportunities and deliver services on behalf of the ICSs, particularly if it states that it can work with very small or very large organisations?
It's quite hard to pick one. So I might have to cheat and opt for two. I think the first one is simplification in the process. There is a lot that can be done, and I do see being done in some places about making it easier for small organisations to respond, sending out opportunities that don't require a team of 5 people to spend a month writing and crafting a response. But I think perhaps the bigger thing is to really listen to what we're telling them, and for the ICTs to be given enough freedom by the NHS England framework to perhaps make more pragmatic decisions that might be the right ones today, even if they're not the long-term aspiration. It's a bit like, you know, right now we want to eat an elephant, and the only way to do that is in very small pieces. And I think a bit of listening and a bit more flexibility to meet the flexibility that we could provide could make an awful lot of difference in terms of, you know, care that we're providing next week and next month, as opposed to in 5 years' time.
Thank you, Emma. That's really helpful. Thank you. I just wanted to thank the audience for the questions coming in. Keep them coming. And I will now introduce you to my next speaker, Anisha Winter. She's diversity and inclusion consultant and will be speaking of the patient perspective. Over to you, Anisha.
Hi, and thank you so much. So my name is Anisha Winter. My pronouns are she and her, and I'm a diversity and inclusion consultant, but I also have lived experience of having or being diagnosed with severe mental health illnesses, which include borderline personality disorder, mixed anxiety and depressive disorder, post-traumatic stress disorder as well. So I've got quite a few of a long list that I've been diagnosed with. Next slide, please. So on thinking about what I wanted to share with you as a patient, and I think it's really important for me to start at the beginning to ground you with the context and understanding of who I am as an individual, because yes, I am a patient, but I'm also a person behind that. And I grew up in a very working class background, and so on the left hand side of the screen you can see the council estate that I grew up on, and that really impacted my level of access to certain services, whether that was private or NHS. There was no such thing as talking about therapy within my household, because I grew up within a quite traditional and very religious household, and talking about mental health potentially meant you was talking about spirits or other things, which was very difficult and damaging for me as a child, because I couldn't really express some of the feelings I was having. And when I was diagnosed with all these different diagnoses 4 years ago, I really was shocked at first, because I felt, how can somebody who has achieved so much, from my perception of being the first to go to university, the first to do a lot of different things that my family members hadn't done, why was I feeling unwell? And did that mean that I failed? And I definitely think me, like many other people who are people of colour do identify our self-worth with our achievements. And so I saw that because I had graduated, I should never have an issue with my mental health. And it was really frustrating for me personally. And a key symptom of borderline personality disorder is having that low sense of self, or that tendency to view things in extremes, or all good and all bad, etc. And if you Google the symptoms of these disorders, unfortunately, I do meet them all. And I feel I still don't quite know myself. I know my trauma and I know what help I need, or I would like to think that I know what help I need. But what's been difficult for me when accessing services as a patient was, one, the way that I'm perceived. And because I can articulate how I feel well, I'm very emotionally intelligent, I'm very in tune with my own emotions, and I'm also able to communicate in a way that, one, doesn't distract from what I'm saying, and I can really get my message across strongly. And so when I first interacted with services, the first thing I was told was, oh, but you're such a strong Black woman, you've done so much already. And I remember immediately feeling frustrated because I'd contacted my GP for support to talk about my mental health. This was a topic that was taboo for me. My family had already told me that talking about your mental health potentially will lead to spirits flying into your head, and they had all these different types of views. And so being told by this GP, a well-meaning GP, to say, oh, you're a strong person, but what that meant was, and the impact that had on me was, it silenced me, because I felt, okay, you're perceiving me as strong. I feel weak. I feel suicidal. I feel like I want to harm myself, and you're not hearing this. So am I wrong about what I'm experiencing? I kept going back to the GP because, unfortunately, you cannot sweep away your mental health problem. And I was then referred to cognitive behavioural therapy. And this was before I was diagnosed with all these different things, but one, that therapy is not useful for someone who has all the issues that I do have. And luckily, the psychiatrist that was meeting with me said, absolutely not, this is the wrong piece of treatment for you. We need to refer you to the IAP team. And from there, I got long-lasting psychotherapy for 18 months. And I really felt, okay, this is helpful for me. I'm feeling like I'm being heard. But then I started to be diagnosed with things. And that was the difficulty for me, because I wasn't told about my diagnosis, as in, it wasn't communicated to me through a verbal face-to-face conversation. I received a letter saying all these illnesses, and I thought, oh my gosh, I failed. I'm a failure. I've let my family down. They've done all these different sacrifices to bring me up in this country. My grandparents were from Jamaica, and they came over with the Windrush generation. So they're very proud people. And so I felt like I'd failed, and nobody from the IAP team was helping with the communication, because they were sending me letters that I didn't understand. I just saw these words and I thought, well, what's the point of going on anymore? I want to share with you some microaggressions that I've experienced with borderline personality disorder, PTSD, or mixed anxiety and depressive disorder. And so next slide, please. And I think these microaggressions really do illustrate my experience of accessing services and the difficulties I've had, and I found them very frustrating at times. But I would like to talk you through them and to share why I think these terms are frustrating. This isn't a space for me to deliver an inclusion training session, but yes, I have a lived experience of these services, and I am a Black woman. I am a Black bisexual woman, and I am a Black bisexual woman with these severe mental health illnesses. And so I implore every single IAP team or service to tailor your approach to each individual. And so one thing that really bothered me was, you sound so normal. When I went into the first meeting with the psychiatric team and was talking to them, sharing my experiences, telling them what I'd achieved in my life, telling them about my family and experiences. I also have schizophrenia. Schizophrenia runs in my family, so my grandparents have it, my mum has it, as well as a few other family members struggle with psychosis. And so to be told you sound so normal compared to the people you're describing was really harsh and harmful, because I don't think we should describe anyone as normal. What is normal anyway? And to be told that, it really, again, exacerbated that distrust that I have. And I think multiple people, particularly people of colour, particularly people with multiple marginalised identities, have with health services. Again, that's trope that I shared there, that strong Black woman schema of that narrative of, you're so strong, you can get through this, you don't look like you're ill, you don't look like you're sick. And what that does to an individual, because do I have to play up to a narrative or do I have to perform in a way that shows you that I need help just because I act differently to how you expect somebody else to act with this same diagnosis does not mean that my diagnosis is invalid. I also was told by another medical professional, and I think this is a really important point to make, because a lot of people in services assume that if you get Black people to help Black people in therapy, then they'll have that shared lived experience, that cultural understanding, and it'll be so much easier. And at times the conversations can be easier because you don't need to go into detail about certain foods or anything that you're talking about in that conversation within therapy. And there has been times where I've had a therapist who doesn't share the same lived experiences as me, and they've told me, oh, I don't know what I'm doing here. I don't know. I've never worked with a person with who's a bisexual. I've never worked with a Black woman before. So I really want you to guide me on this experience. So then my trauma and my therapy became me facilitating a conversation for the IAP team. And how unhelpful is that for me trying to get help? But the reason why I say that is not because I'm completely angry at that team at all, but I think it's really important to note some comments that you make can be really harmful, and the narratives that we paint around other individuals can really hurt. And I really want to bring it home to the fact that where we talk about with mental health services and health inequity for racialized backgrounds, having another Black therapist isn't helpful if they have the same stigmatizing thoughts about people with personality disorders, or about this Black woman's letting the race down by presenting herself with these mental health illnesses. And I was told, you just need to pray more, by another Black woman who was my therapist. And how frustrating is that? That one, yes, I am a Christian, but two, it's not helpful if I'm coming to you with help. So there's a whole lot of microaggressions that are thrown at Black women within mental health spaces that we need to be aware of. But also, when you compile that experience or compound that experience with having severe mental health illness is diagnosed, and you have those stereotypes and stigmas applied to that as well, there is just so much oppression you're trying to navigate throughout these spaces. And I think it's really important to share my experience, because it is a true lived experience, but also to provide space for us to think about how we can not replicate these same mistakes in our future practice. And so, as I said before, when people said you aren't like them, when I've met borderline personality disorder other patients, or you're not as bad as them, or they're the criminals but you're okay, and the language and the message that brings to an individual to say that because I have this diagnosis, I am perceived that I am going to be like this, or people won't like me because I have this diagnosis. They're going to assume that I'm manipulative, etc., etc. I'm sure you're all aware of the many different stigmas and stereotypes around all these different disorders. And then the final one that really, really hurt me was you are intimidating to others. When you are a woman and you are asking for specific support, you can often be either gaslighted or mansplained, specifically within mental health services because you are told that, are you sure you need this, or why are you asking for this, or are you sure you heard about this, or did you speak to this person? You're constantly questioned, you're constantly gaslighted. And I think there is a underlying issue of sexism within the sector as well, of how women are perceived as hysterical when we are asking for help. But also there's a racialized issue there of these are hard to reach communities. And I really hate that term, because I don't think any community is hard to reach. Our approach or our research just need to adapt to that community. And that's the message that I really want to drive home today. Next slide, please. And so I've got a quote for you all from myself as part of, I delivered a TED talk last June on vulnerability being your superpower. And I think it's so important for people to reflect on why having a patient in these spaces and in these talks today matters, and why having that lived experience of a patient and not somebody who is delivering a service or creating a service. Because I think patients are experiences of how services can be improved. We know the knowledge from what we would like to ask for, or from what we've seen others receive. And so I really want to just share this quote of, once you know in yourself who you are, nobody can take that away, that light inside of you. And I think for me personally, once I knew that I had these diagnoses, I worked on myself of researching, and there's so much on Google you can see and access that can feel really, really intimidating. And then you're navigating microaggressions or different systemic issues within the mental health services. It's really important for me to know that regardless of how others perceive me, regardless of what stereotypes or stigmas they hold in their head about my illnesses, I know who I am, and I know where my heart is, and I know who I want to be. And so on the next slide, I've got a few takeaway thoughts for you all, and from my perception of what can be improved. And I think it's really important to check your language and to hold your assumptions. We talk a lot about unconscious bias in these spaces. We talk about the biases we bring into our service or our research, etc. But really think, are you using language that says them or us, those hard to reach communities? They're making it difficult. They've got distrust. Why are we not using language that is we? How can we move together for as a collective and collaborate as one? And so I've just got asked questions here as well. I think it's so important to ask questions of patients and not to assume that because I'm a Black woman, I'm not going to want to talk about my mental health. That's really silly. But these are the biases or stereotypes that people have. And yes, it is true for my familial experience that we didn't talk about our mental health. And it was a very difficult topic. However, I was constantly and consistently searching for a place where I could do that. I also think it's really important to allow lived experience to lead and guide projects and processes. So if you are doing a new intervention for borderline personality disorder or any of these severe mental health illnesses, who's leading it? If you haven't lived what I've lived, you can only be informed by research, and you need to make sure that you co-create and co-collaborate with lived experience experts and your experts in your own life. And I think that's really important to note, as well as being open to getting things wrong and being accountable for your own learning. So yes, it was very problematic for me when that therapist said, you know what, Anisha, I don't know about racial issues. I don't know about biphobia, homophobia, none of that. I need your help. It was frustrating and it was the wrong space for that person to ask. However, please do take your learning outside of this space and don't think, oh, I can find this specific patient, that one other Black therapist that might be able to help them, because that's not helpful. We all need to understand these issues and we all need to learn more about each other. And also know that silence is being complicit in oppression. There's so much stigma and stereotypes and harmful language thrown out about people specifically with borderline personality disorder. Know that if you are hearing those conversations, if you are being a part of that conversation and not challenging it or calling that behavior or language out, you are continuing that cycle, that it's okay to see borderline personality disorder patients as evil, manipulative, or however we've been described. And I've heard many comments before, and I'm sure you have as well. And so I think for my hope and for my desire, I really want this conversation to continue, but not to just have this conversation of what interventions can we put into place, because yes, that's useful, but what interventions can we put into place for all different types of people? And not only all different types of people, all different types of backgrounds, all different types of languages, experiences, the ways we communicate. If somebody's communicating a lot with their hands, are we going to deem them as threatening, or are we going to keep learning about different cultures? Some cultures don't like eye contact. That doesn't mean I have a mental health issue or I'm evasive. Don't put that on somebody's notes. And really just keep diversifying your approach to engage all communities, because as I said before, that hard to reach community, those difficult communities, that language needs to stop. And we need to leave that in 2021 and really move forward with knowing that all communities are engaged. It's just we need to be knocking on the right doors and listening to the right voices. So thank you very much for listening to my experiences. I'm very keen to hear any questions that you might have about my experiences. And thank you very much for giving me the time to talk.
Thank you very much, Anisha. Very thought-provoking presentation. A strong call to action there. Agree with you wholeheartedly. We need to allow lived experience to lead and guide us in designing our services, co-producing them. I think gone are the days where we do to people. We need to do with people. And thank you for sharing your experience and giving us an insight into your journey. I do have a question for you. I think we have enough time, yes. What would be different as a result of tackling racial injustice, and what's the change you'd like to see?
So the change I would like to see is, I think we're all aware of the racial injustice or health inequity when we're thinking about race and people from racialized backgrounds. And so the statistics are there. I think what I would like to see is action. I would like to see co-creation with organisations that specifically work with certain marginalised communities, because they have the people there that are the hard to reach communities. And so to see more collaborative projects would be a huge thing, to see projects led by people with lived experience. So we're really putting our funding behind the activists or advocates within this space that really know this work because they live their illnesses every day, or they live their experience every day. And so I would really like to see that moving forward. There's been so much conversation about language changing and whether we should use emotionally unstable personality disorder, borderline personality disorder in general. And for me, I'm not so hung up on the language. I'm more worried about the disparity in treatments and services. And so for some people with personality disorders, they receive a really quite comprehensive experience of treatment, and for others, they don't receive specific experience based on their diagnosis. And I fall into that category. And so I'd really like to see an implementation of services for everyone. And that's really tailored to the individual and their individual needs, and not just what do we have funding for. Because I think there's so many people within the mental health sector, mental health patients, that have been shafted or just not given the support that they do need. And I think I would really like to see that universally across the whole of the United Kingdom, and not just in London or certain areas.
Excellent. Thank you, Anisha. I think we can all learn a lot from what you've just said and the advice given. Thank you. I think it's time for Q&A time. So I'm going to just check what questions have come in and direct them accordingly. Bear with me. So loads of questions have come in. Thank you, everybody. And if we don't get through all the questions, I think the answers will be posted on the Q&A section. So all your questions will be answered. So I'll go in the order that they've come in, actually. A question for Zora. Someone asks, it's great to hear about digital outcome measures, measure collection, but does this improve collection rates? Does that make sense to you? Yes, let me read it again. Great to hear about digital outcome measure collections, but does it improve collection rates?
I'm going to give you a half answer to that, which is I believe so, but I don't actually have the numbers to hand. I just have a discussion with my colleague who runs all the numbers regularly just last week, but I just can't remember them. So what I'll do is take an action, if that's okay, to get back to you with evidence of it, but I think it does.
All right, thank you. My next question is directed towards Emma. And a question come in says, why is the voluntary sector so crucial to mental health services, and what specific and different skills do you bring?
Oh, I think I already touched upon the fact that in the voluntary sector, you often get specialists within their field who are maybe attracted to working together. So I think I gave the example of, you know, eating disorders. There's a great organisation in Bedfordshire that is a real centre of excellence for eating disorders. But I think it can also attract people who maybe don't want to work for a large and, you know, at times bureaucratic organisation such as the NHS. So I think, you know, in terms of having a much greater access to talent and skill and trained experts who are committed to this sector, I think it broadens that. And I think, you know, sometimes people are suspicious of the NHS. Sometimes people don't want to access care through their GP. There can be a whole host of reasons why statutory bodies can feel like a scary barrier to many people, whereas approaching a voluntary organisation can feel less scary, less intimidated, less terrifying. And I think, you know, a number of the other points that maybe I touched on, you know, listening to Anisha, as smaller organisations, we can often be closer to our clients and the client experience, and to respond rapidly to feedback that we're getting, and, you know, how we develop things in partnership with the communities that we're located in. I mean, I could go on and on about why the voluntary sector's, you know, important, but, you know, I'll stop there.
Great, thank you. My next question is to Anisha. Somebody writes, thank you for sharing your experience. I agree. What is normal? And as a carer and patient, how can we be treated more respectfully without being classed as difficult?
Well, I think that's an interesting question, and I think it definitely puts the onus on us as patients to not be seen as difficult. And again, what is difficult, depending on who you're working with, some behaviour might be difficult and some might not be. But what I've found works really well to communicate my experiences without seeming difficult is to write down or to keep a journal of the symptoms that I'm having, so I don't feel like I'm being questioned or gaslighted or feeling like I'm being denied, but really I can visually show, even if I can't recall what's happened, I can show from my journal, this is my experience, or this is the symptoms that I've been having recently. I think when it comes to being seen as a difficult person, definitely raise a complaint if you do feel like you are being labelled as difficult in times, because I do think that sometimes there are people within the sector who, I won't call them bad apples, but can definitely reinforce stereotypes and stigmas for people with personality disorders or other mental health issues. So definitely challenge them, because we need to be holding people to account as well.
Brilliant. Thank you, Anisha. And lots of words of thanks come in for you. So do have a look at the Q&A section. We've got about 4 minutes left. So I'm going to very quickly round off by asking you all for a sentence each. And I'll ask it in the order that you present it in. What is the one thing you would change to improve outcomes for those impacted by mental health? Okay, so we'll ask Zora first.
Hopefully unmuted.
Yep.
Am I unmuted? Okay, great.
Yes.
That's a tough one. I think the one thing would be looking at the biggest opportunities for increasing access and addressing those very systematically.
Thank you. Emma?
For everyone involved in mental health care to acknowledge and be aware that there are many things they don't know.
Thank you. Thanks, Emma. And Anisha?
For patients and people with lived experience, for their time and their voices to be valued and to be included in the co-creation for new projects, new research. And so we aren't just the afterthought or the result, but we're there from the beginning and all the way throughout.
Absolutely. Brilliant. Thank you so much. I wish this webinar could be longer and I could talk to you all for longer, but we are coming to the end. And I'd like to thank everyone for joining and thank all our speakers. We hope that you can join another one of our webinars in the future, and look out for the recordings and the summary in the Q&A, which will be on the webpage soon. Thank you so much, everybody.